Good morning, everyone, and welcome to the Arineta Symposium here at FSCCT. My name is Sayali Tarlekar, and I am the Global Head of Marketing at Arineta. It's always a pleasure to be among champions and advocates of cardiac CT. Arineta is fully committed, passionate, and dedicated to advancing cardiac CT. We are the developers of Spotlight and Spotlight Duo, the world's first and only dedicated cardiothoracic CT systems. So, our vision as a company is to establish cardiothoracic CT as the frontline, non-invasive test for diagnosing, therapy planning, and monitoring cardiovascular and thoracic diseases, the leading causes of death and healthcare costs worldwide. We believe that cardiac CT has the potential to be a transformational technology that can change the course of these deadly diseases. We had to make some changes to our agenda today. Unfortunately, Dr. Jonathan Leipzig couldn't be here. I'm sure you've all heard of the Microsoft fiasco that happened yesterday, which has delayed and canceled a lot of flights. So Dr. Leipzig has apologized. He said hello to you all, and he's stranded in Canada. He really tried hard to make it. He's still trying to get here, but he definitely cannot be here at 7 a.m. So we are starting our presentation with the next exciting talk led by Dr. Neerav Sheth. And I am now going to introduce you to Dr. Sheth. Dr. Sheth is an interventional cardiologist and multimodality imager based outside of Philadelphia. He attended the University of Pennsylvania for his graduate degree, medical school at Northeastern Ohio University's College of Medicine, followed by an internal medicine residency at Thomas Jefferson, cardiology fellowship at Penn State Hershey, and interventional cardiology at Providence Hospital and Medical Center in Detroit. Dr. Sheth received his MBA from George Washington University. His multi-boarded in internal medicine, general cardiology, interventional cardiology, cardiovascular CT, echocardiography, nuclear cardiology, and vascular interpretation. He is a level 3 CT reader for Mainline Health System and has recently launched an Arineta Spotlight Duo CT scanner for his own practice, Cardiology Consultants of Philadelphia, to bring cardiovascular CT imaging to the forefront of private practice cardiology. And Dr. Sheth is going to tell us about why he chose an Arineta Spotlight scanner and why you should consider one too. Please join me in welcoming Dr. Sheth.
All right, thank you for the introduction, and thank you all for being here. I know it's early in the morning for this talk. But this is something that is very fresh for us because we literally just launched our scanner about 6 weeks ago. And so far, so good. So, disclosures, I mean, I do work for some imaging companies as a consultant speaker, and I do consult for multimodality imaging around the country. So, introduction, who are we? Cardiology Consultants Philadelphia. It's the nation's largest private practice cardiology practice. We have over 100 cardiologists and about 40 to 50 advanced practice practitioners, between nurse practitioners and PAs who cover the entire southeastern Pennsylvania region, from Philadelphia up to towards Bucks County and to the west past Chester County. And our patients come from the entirety of the southeastern Pennsylvania region, from even further north. They'll travel a few hours to come see us, out also from Delaware and New Jersey. So it's a very large catchment area. We probably service about 1.5 million patients across that region. We work with multiple health systems, including Penn, Temple, Jefferson, Mainline Health. Some of our patients are at Cooper, and all the smaller sites in between. We have a full range of inpatient, outpatient services, and you can see the list there. Between PET CT, vein, vascular, ultrasound, echo, and now cardiovascular CT. We also do all the service lines in the cath lab that you can imagine. So coronary structural intervention, electrophysiology, peripheral intervention, CLI, renal work, and so forth. So that said, it's a large patient population with a very wide payer mix. And we do participate in local ACOs, MIPS, MVPs. I'm personally involved with some ACC and SCCT initiatives discussing reimbursement with CMS, Medicare, Medicaid, and reimbursement. And so this is something that made a lot of sense, once you look at it, and I'll get into that in a minute. So traditional diagnostic workup, we've all seen this stuff before. You have your history and physical exam, your labs, your EKG. You have your stress imaging, nuclear, echo, CMR, PET, and then you have your invasive angiography. This is the traditional stuff that we sort of grew up with up until about the late 1990s. And then things got a little bit more advanced. But when you look at the diagnostic sensitivity and specificity of each of these modalities, the reality becomes you can detect obstructive disease once it flags on a stress test or the patient has symptoms, right? And that usually takes a 60 to 70% stenosis. What about before that? The only ways to really look at stenosis below 50% in an asymptomatic person or mixed symptomatic person is coronary angiography, now CT angiography. Occasionally you might get lucky with a calcium score in an asymptomatic patient, but realistically, unless they have symptoms, you have no idea who's walking around with heart disease, right? Unless you do your screening and your management evaluation, they happen to be referred to a cardiologist early, they happen to have a family history, but I'm sure everyone can attest that there's a large number of people who have no symptoms who are high risk. So how do you find them? You can do your non-invasive functional testing, but all of that has limited utility. There's large false positives and false negatives depending on your modality. Nuclear imaging is obviously better than echo. Stress echo, for those of you who aren't aware, in the real world population has about a 40 to 50% sensitivity and specificity. Because by the time that person gets off the treadmill and gets imaged, their heart rate's dropped, and you can miss that actual stenosis. Now we're not talking about academic centers who might have everything streamlined, but the real world, private practice. SPECT and PET, we see images with diaphragmatic attenuation, soft tissue attenuation, weight restrictions, and so on and so forth. We don't really see a lot of false negatives these days, but they do happen. So because of this and the need for more, there's been a wealth of information, and we've all seen this, at this point in this conference, that the 2021 multi-society guidelines have come out to recommend cardiac CT as the next step in, the next wave in early diagnosis of heart disease, right? And this is the proposed paradigm, and I'm sure people have seen this before. This is just from the guidelines, honestly. Intermediate to high-risk patients with chest pain, think about your cardiac CT as your imaging modality of choice. Now, this is all well and good in a hospital setting, but what about in an outpatient setting? What do you do in the outpatient private practice imaging, setup? And so what we wanted to do is build an outpatient high-quality imaging program, okay? So why? We want to offer high-value, high-quality care in a more affordable setting, offer care in a timely fashion. From my discussions with people this morning and throughout this conference, the average delay for getting a cardiovascular CT in a hospital system ranges anywhere from 6 weeks to 3 months. And frankly, we were just discussing that this morning, some of that has to do with the fact that the hospital infrastructure has not been updated to manage the exponential increase in volume that happened when those guidelines came out. The second the guidelines came out, everybody ordered a cardiac CT. And in a hospital, you have beta blockade needs, you have patient bed needs, you have nitro needs, you have monitoring, all those things that happen. It could take 3 to 4 hours for one patient to get a cardiac CT. Exponentially multiply that into the millions, you can see where we have a delay. You can develop an outpatient chest pain program. You can develop an imaging ecosystem, and I'll talk about that in a minute. But you can also streamline efficiency for ambulatory surgical centers, and I'll talk about that as well. Because whether we like it or not, there are certain realities that are coming, ambulatory surgical centers, outpatient imaging centers, hospital consolidations. There's a lot of stuff that's coming, and how do you navigate all of that and still provide appropriate care to your patients? So high quality care in a low cost setting, why is this important? Office-based testing is billed at lower rates on hospital-based testing. We've all seen this. The multiplier is 2 to 4x, depending on where you are in the country. A stress echo might cost you $300 in a private practice in an office versus $1,200 to $1,800 in a hospital. I mean, these are the actual bills that patients are getting. So what that does is, when you put it in the outpatient setting, you have a lower copay for your patient. You can have more cost-effective care and, again, more timely care. Everything is better managed, and more transparent in the private practice versus a hospital. I mean, if anyone's looked at a hospital bill, even when I look at it, I can't understand half of what's written there until you make a phone call and say, what is this charge? What is this charge? In the office setting, you actually have more control over that, and we can do cash-based pricing for a CT, for an echo, for everything. And so our patients actually don't want to go to the hospital anymore. They want to come to us and get it done because they know what they're getting. Offering care in a timely fashion. You maintain control over scheduling, administrative burdens, backlogs. You can maneuver your schedule. We offer this dedicated scanner 5 days a week from 7:30 to 4. There's a large number of patients that you can get to in that timeline with better outcomes, honestly. The graph on the right is from Scott Hart. We've seen what happens when you diagnose people earlier. You get better treatment, you get more medication adjustments, you get more preventive care. 41% lower death and MI rate at 5 years. And this is a very poignant graph that I use in a lot of my talks, simply for the fact that you can know that if you diagnose somebody, you can take better care of them and they're going to be more alive at 5 years than not, and in better quality of health. You can create a chest pain outpatient program. Somebody gets discharged from the emergency room for chest pain with a normal EKG, normal troponin. They go see your doctor. Well, then what? You have the ability to do a 48-hour turnaround in an outpatient scanner and say, yes, you have coronary disease. Maybe we should adjust your medications, or you might have something more problematic and needs to go straight to the cath lab. So these are ways that we can offer care in a timely fashion for our patients, and improve the quality of that care at a low cost. Cardiovascular ecosystem. So diagnostic imaging modalities, are not supposed to replace each other. They're supposed to be complementary to each other. That said, using the correct test for the correct patient at the correct time in their diagnostic life is really important. Getting this test, which is an anatomic test, it's not a gray zone. It's like, is it a blockage or is it not? Is there calcium or is it not? It's a yes, no scenario. Yes, there are some nuances to the interpretation, but you're much farther ahead and you can avoid layered testing. You can avoid that treadmill stress test that might have a non-diagnostic finding, or they don't meet their 85% sensitivity. And then you get your nuclear testing, which might have some diaphragmatic attenuation, and then you get your coronary CT, and then you get your catheterization. You can skip a lot of those steps. Again, lower cost to the system, more efficient healthcare. You can implement AI for all of these modalities, honestly. So, we've all seen some of the HeartFlow and Clearly data over the last couple of days. HeartC is what we use for our AI development for PET-CT. And the PET-CT we would use for patients who can't get a cardiac CT, either renal dysfunction, they've had prior CABG revascularization, where zones of ischemia evaluation are really important. And then you can optimize patient care, algorithms, databases, data mining. How many patients do you have that have an aortic root of 4.1 on an echo that get their routine echo every few years? You can build an aortic CT program. You can build a vascular program. You can build all of these things and get the patient the right test. It prevents over-ordering, and it also prevents under-ordering. So you get appropriate follow-up for your patients. Streamlining for efficiency for ambulatory surgical centers. Now, this is something that's now coming across the country. Many states have ASCs, and how do you, from a business standpoint, optimize your ASC? You want your low-risk procedures, you want your planned procedures, and you want things that are going to be predictable, and standardizable across the board for every patient that you send to an ASC. Simple, straightforward, low-risk procedures are ideal. A type A LAD, you can do in an ASC, without needing surgical backup. If you see a large calcified burden on your CTA, you're not going to do that in an ASC just because you're going to need to do atherectomy to open up that lesion and properly deploy that stent. Same with the peripheral vascular space. If you see a low-risk SFA stenosis that can be done, do it in an ASC. Again, lower cost of care overall to the system. ASC reimbursement is, professional fee is higher for the doctor. It's 50% on average lower cost to the insurance company and to the patient compared to a hospital setting. So again, lower cost to the system, more efficient healthcare. So how are we doing this? We did install a Spotlight Duo scanner. Small footprint, single bead acquisition, less need for aggressive rate control. This is important because you do have some wiggle room, not as much as we would hope, but if you can scan at a heart rate of 70, get a reasonable scan, I mean, that's preventing somebody from needing an extra 100 milligrams of metoprolol or ivabradine or something to really knock their heart rate under 50 like you would need for some of our older hospital scanners that are now cranking out high volumes. You do multiple scan protocols. We're doing coronary, vascular, aorta, peripheral vascular. We're going to be doing carotids, in the near future. So it can do all of these things. We're also running a PE program and a chest nodule evaluation. For all those nodules you see on calcium scores, they do need to be followed, right? And so we have a lot of requests for some of these types of scans, simply for the fact that our patients can't get into hospitals for their CTs, their annual follow-ups and so forth. Short throughput time, 30 minutes or less from start to finish with single bead acquisition, and high volume capability. The expectation is 20 to 25 scans a day. Now, operationally, you have to figure that out, right? You need your installation space, your HVAC, your electrical, your financing, patient flow, selection management, image interpretation, overreading. We contracted with a company to help us with the overreads because I'm an interventionalist, a multimodality imager. I cannot read 100 CTs in a week. Myself, I'd have to quit the rest of my day job, and that's a no-go. So we need help, and this is something we're seeing around the country is people are getting CTs, but the delay is in getting it, scheduling it, the scan itself, and then the interpretation. The volume management, expectation management has to be there. So we contracted with an outside service to help with the additional reading. Before launch, we had 50 requests for test patients, 50. Within a week, 2 weeks after, we've had 300 requests for CTs. And so we're fine-tuning some of our protocols, but that's what we're looking at. Again, large patient volume in a high-need area. So let's see this is actually our scanner, being dropped off. That's it. It's not a massive piece of equipment. It is, not very large. So if you haven't stopped by the booth, I would encourage you to stop by the booth. This is literally our scanner. And then this is me in our scanner because I was patient 0. The first test patient getting done. And it was a very smooth procedure, in and out, the IV, everything from start to finish. And this is what our patients go through. So when people ask me, well, would you do it? Well, yes, I did it. So I can actually show them, I said, this is what you did, this is what we did, this is how it feels, and this is what you get, okay? And then some of our test patients, not me, some of our test patients, this is a testament to the quality. This is the first day with the scanner. On the left, you can see pretty normal, minor luminal regulars. On the right, asymptomatic test patient. So this person then went on to get an exercise nuclear stress test to define if this is truly an ischemic zone or not. Now, we were working on other algorithms like heart flow and clearly and so forth, so plaque analysis, and that's coming in the future, but this is what we find. When my previous CT launch in a different state, we found aneurysms, we found triple vessel coronary disease, we found all sorts of things in asymptomatic patients, and now we're able to take care of them. This person now is on maximally tolerated statin therapy, aspirin, plus other anti-anginals. And so why is this important? Is because when you look at this chart, this is what happens. So his life expectancy just went up just by getting the CT scan. And he's a cardiologist. So the downstream effect is massive on that, okay? So conclusion, we chose this because it was the perfect addition to our existing infrastructure. We've already seen increases in other service lines. You know, 50% of these patients, not just the ones I showed you, went on to other testing. A handful actually went to cardiac cath because there was a graft that was jeopardy. And so catheterization, echo, vascular imaging, you know, so when it's implemented correctly, a CT program that's outpatient with or without AI offering, depending on your business model, can enhance your cardiovascular offerings, improve your outcomes, and improve your overall bottom line. You know, just from a private practice financial standpoint, everything improves. And this is our team. Any questions?
We've got one question.
Yeah.
Just a practical question. To optimize the scanner to the most productive fashion,
Sure.
do you have dedicated days for calcium scoring versus dedicated days for CPAs? Because you don't occupy with the calcium scores, right?
Correct. Yeah. So we have right now, because the volumes are on the lower side, and that's intentional. It's not, we don't have we have over 1,000 CT requests right now, but we are intentionally keeping the volume low just to tweak our protocols and our patients. But eventually, yeah, we're gonna work our day around doing, say, calcium scores early in the morning. You know, because we start our program at 6:30. And we may not have a physician on site at 6:30, so you can do a calcium score, but you can't do a contrast study, or you shouldn't necessarily, right? There's medications, there's reactions, and so forth. So once our protocols are streamlined and our processing is done, and we shorten our throughput, then yeah, we will actually have dedicated times, like probably beginning of day, end of day, for calcium scores, and then maximize the contrast studies when the physicians are on site. Good question.
Do we have any more questions?
And my contact info is up there, my cell phone, so if anyone has questions, please feel to take it down, and I'm happy to discuss.
Okay.
If you need to do something other than cardiothoracic, does this scanner perform brain musculoskeletal?
Can it do brain? Yes. So we are going to do carotids on it. Will we do cerebral imaging? Probably not, unless it's a follow-up of something. There's a lot of nuance to that. We just did a couple of EVAR and dissection follow-up scans, and runoffs. So I have some SFAs I have to fix because of the runoff scan. So it can do everything. Would I do it for the intracerebral, like an A2 stenosis or an aneurysm? Probably not. I might send that one specifically to the hospital just for the nuance of the reading that comes to it. Like, I can read everything from here to the toes. The intracerebral, I'd rather a neurointerventional or neuroradiologist read it, just for a liability standpoint. You know. But to answer your question, the scanner can do it. It's just your reading infrastructure has to match what you're doing.
I was curious, why specific for cardiovascular? What is the unique software, hardware part of this scanner?
Mm-hmm. Well, so the gantry doesn't move. That's really the big plus here. You know, it's a 500-pound weight limit, but you put the patient in, and for the runoff, it's a step and shoot situation. But you center the patient over the part that you want to scan. That's why it's ideal for chest, thorax, aorta, and areas that are not going to be running chasers. If you're going to do a chaser scan, those are best on like a Siemens dual source in the hospital, where the whole thing will actually move and follow it. But those are not what you're going to be doing in an outpatient setting, right? But if you're going to maximize throughput in the outpatient setting, it's the chest pains, the coronaries, the aortas, the follow-ups, those sorts of things, because it's not just a matter of the scanning. The scanner can do it. It's the interpretation, the follow-up, and so, for instance, the dissection scan I just looked at yesterday, that requires follow-up, looking at the op report, comparing to a previous scan. There are all those things, so patient selection is really a big part of how you're going to improve your throughput, and make sure you're not staying up until midnight reading these.
All right. Thank you, Dr. Sheth. I would now like to introduce you to Dr. Jamie Warren. Dr. Warren currently serves as the Vice President of Care Transformation at MedAxiom, an ACC company where she specializes in operational leadership. She holds a Doctor of Education in Leadership and Learning in Healthcare Administration, an MBA, and a Bachelor of Health Science in Nuclear Medicine Technology. Dr. Warren brings over 25 years of clinical and operational cardiovascular and imaging experience to her role and is actively involved in numerous boards and committees dedicated to advancing cardiovascular imaging for patients. Dr. Warren will be talking about launching a successful cardiac CT service, collaborative solutions with Arineta. Please join me in welcoming Dr. Warren.
Good morning, everyone. Thank you for the introduction. So we're going to step over into the space of talking about operational success and starting and scaling a CT program. So I have no disclosures. Just for time, I'm going to flip through our objectives here, and then we'll start. So as in the previous discussion, in the 2021 chest pain guideline changes, we really saw an explosion of attention when it came to CT diagnostics and being able to offer this over into the cardiac space. The other piece of this is really the role of cardiac CT as it really crosses all phases of the care pathway. So not only are we developing a diagnostic tool for diagnosing patients with new disease or progression of disease, we are also looking at therapy planning and treatment, monitoring short and long-term outcomes, and prevention and wellness. So with this, we often see that our cardiac CT programs are sitting within the four walls of our radiology departments. And with the extra attention on cardiac CT, we started to see that we ran into a real problem of being able to scale our cardiac CT programs just with being able to get table time. And so what this has done is it's caused cardiology to hit the pause button and say, is it time for us to evaluate managing our own cardiac CT programs? So in that then starts the questions of, what are we doing today and what could we do tomorrow? So a couple of considerations as you're hitting that pause button and thinking, is it time for our practice or for our organization to evaluate cardiology managing a CT program, is what is going on with the current program. So a couple of questions to leave you with is to think, who are these patients? Why are they coming to our department? What is the ordering reason why they're coming in? The next piece is who's ordering these studies. So is it inpatient? Is it ER? Is it outpatient? Is cardiology the primary order? Is it primary care? Could it even be a different specialty? And then the bigger piece of that is who's reading. Could it be cardiology? Is it radiology? The next piece of that is where's our growth potential? So it's where is the new use cases for CT? And that is, again, with our chest pain workup, but really diving down into our additional programs with structural congenital heart and with our EP. So once you've hit that pause button, you say, yes, I want to move forward with really developing out a plan, you start looking at equipment and space. But then the other piece of this is really to look at the operational aspects of this to have a successful program. So as we look at data that we are able to get through MedAxiom and our partners, with this, we've trended over 2019 through 2023. And I will be surprised. When I saw this graph, I knew CT was one of our most growing modalities, but when I saw this, I was like, wow, that's impressive. And this is really why we're hearing the pain points of that funnel that's trying to come into radiology and us not being able to get patients. We just recently had a discussion this morning. We were saying that a lot of our radiology partners, it may be 3 weeks, 3, 4 weeks, 6 weeks, 8 weeks to be able to get that patient in for a CT. So we are excited this morning to announce our partnership with Arineta and MedAxiom, that their new customers who purchases an equipment also have the option to work with MedAxiom from an operational perspective and being able to map out a custom plan for a successful plan to opening up CT and then scaling. So you may be asking, okay, well, what's part of that operational plan? These are the 10 buckets that we would come in and evaluate, but I also would say this is a great checklist if you're going to start your program of the different areas that will help to be able to have a successful program. We're going to spend a little time in each one of these. So our first one, you've got to evaluate where you are today. What does your current team makeup look like? And this starts with your physicians, but it also starts with your staff that would be performing the test and your staff that would be supporting testing. So this is reviewing the qualifications of the current team, verifying their compliance and certification. I will say this is putting in short and long-term goals. Do we have a group of physicians that are already reading CT or need to be able to obtain education to read CT? Do I already have a technologist that's on my team that can perform CT, or is this something that I need to start looking from outside and hiring in? And then it's also about implementing continuous education. We'll talk about that a little bit further in the next couple slides. And then the last piece is how do you set up peer review? This is a new product that may be part of your cardiology program, and you do want to ensure high quality, both from an imaging perspective and from the reports. The next piece is evaluating your job description templates and market analysis. For many of us, we don't have a CT tech that's sitting within our office space that we could just move over, and so this is evaluating hiring onto our team. This is putting together job descriptions that make it attractive that you become the employer of choice, that a CT tech that is at a different location would want to join your team. This is also the opportunity to hit the pause button and evaluate who's going to do what. So this is talking about the roles within your department. We have seen different combinations of CT techs, nurses, MAs, imaging assistants, and it really drives down into what would be the workflow in your department. So thinking about who gets the patient, who does an H&P, who starts the IV, who administers adjunct medications. And then also, it does come down to pay. Are we going to be a competitive payer, but what does that mean? What does the salaries look like in your local area? And then being able to use that as a benchmark to then set for your location. Training pathways. So with the CT space, it's very important to evaluate your state requirements and what's required for what I would say who can press the button, who can take the actual images, and then who can do the processing. The other piece of that is making sure that they have the appropriate education and board requirements, that your physicians have completed the appropriate training. And then the bigger piece, especially in cardiac CT, because I think every day something new is coming, is how do you keep up with continuous education? Because what you learn today, you have a whole bunch of other things to learn 6 months from now. So it's putting a plan in place for that opportunity for continuous education. Radiology partnership, we just kind of talked about. So how do we collaborate within the space of the radiology partners, a third-party company? And then this is also identifying if you're going to use radiologists to do an incidental finding report. CT compliance guidelines. So we're talking CT. We now need to talk about radiation safety and then also adhering to the CT regulations. And this is also looking to making sure we have the appropriate documentation saved and that our staff is following appropriately. Out of all the slides that I will give, I will say that this is probably priority 1 when it comes to the buckets. And this is our revenue integrity analysis. And you're starting a new service. This is really diving down to make sure that you were set up for success on day 1 and not 30 days in and having your billing department come to you and say, we need to talk. So from day 1, this is being able to have those conversations with your commercial payer contracts and negotiating. The prior authorization process, this is really a 360 view from this. This is starting from the provider that orders the test and ensuring that they have appropriate documentation, all the way down to the person that is contacting or reaching out to the insurance company to ensure that they have what they need to get that prior auth. Accurate coding and documentation. If you are using an EHR system, it's going in and looking at your order sets, making sure that you have the appropriate charges that are dropping, and then at the end, efficient reimbursement processes. Accreditation guideline. So if you are going to be in-office based or if you're going to be hospital, the conversation of do we need accreditation is going to apply. There are a couple of options as you go to look at this from IAC to ACR. One of the things that I will say, especially in the office based, is take a look at the other areas that you already have accredited. So for many of us, we hold accreditation in our echo departments and our nuclear departments and our PET departments with IAC, and it is a very streamlined process to be able to add the CT modality to it underneath your current umbrella of accreditation. The other piece of this is evaluating the application process. So if anybody has gone through accreditation, sometimes that can be very intimidating, and it's who has the staff and where do we go and how do we put these places. This is about being able to put a checklist into place to very much ease that into hitting each point that needs to be completed from the application process. And then also from accreditation, it's not just we're going to send it in and then we're good for 3 years. There is some maintenance that needs to be done during that time, and this is evaluating how to set up a plan to ensure that you are meeting the accreditation standards. A quality assurance program. This is very important as you're starting a new imaging modality, that you have a method in place to be able to evaluate where you are from a quality assurance program perspective. It is one of those things that we can't just make the assumption that this is going to naturally happen. Instead, this is about putting a plan in place from day one, and it's communicating it out from both the technologist side, from your imaging staff, and from the physician. It is also looking at your patient safety protocols just to ensure that you do have those safety tips in place. Out of the other buckets, I would say this is the second most important when you're developing out your plan. So unfortunately, in cardiology diagnostics, the philosophy, if we build it, they will come, doesn't usually happen. And so this is really taking an evaluation of how are the patients going to make it into our CT department. And so that starts internally. So if I have this from a cardiology program, how are my own providers going to be ordering into the CT department versus one of our other imaging modalities? But the other piece of this is how are we going to outreach with our referring physicians? So is this primary care? Is it subspecialties? But how are they going to know that you've now offered a new imaging modality and that you have access and that you can get the patients in very quickly to be able to do their test? So this is developing a very robust marketing plan to be able to communicate that out to your other partners in care. And then it's about building those relationships. I always say that we are all looking for the easy button, right? The path of least resistance. I need to schedule a patient to rule out for X, but where can I get them in the fastest? So access, access, access. And if you're the location that you can get that patient in within like the next day or within 2 to 3 days, you become their choice of where to send their patients for their imaging. Educational material. This is a new test a lot of times for our patients. So patients that you may have seen in the past, they may be familiar with echoes, they may be familiar with nuclear, they may be familiar with stress testing, but now you say to them, I want to do a CT, and they may be like, I don't know what that is. I don't have a family member that's had that before. And this is about being able to hand them a brochure or a handout that gives them some additional information. I always say that when my mom goes to the doctor, I always say to her, hey, if they order something on you, please bring something back to me so we can read it together. And so it allows them to have that information to say, this is the type of test that's going to be done. And the other piece of this is training materials for your healthcare providers. And again, this is partnering with them to say, these are the reasons why you would order this particular test. It goes back to the right test for the right patient at the right time, but it's also being able to provide some information to our providers to clear up the confusion on which test is best. So next steps, if you're thinking, oh, this sounds great, how do we get some additional information? So if you will reach out to Arineta, they would be able to assist you both from a camera and space planning, but then they can also have discussions from the operational component. And then if you have any questions for us at MedAxiom, we would love to have them. You can reach out to me also. Okay. Any questions? Yes.
It's a question/comment. The text, getting good text to do coronary CT is essential. If you don't have a good tech, you might as well go home. And yet, in our environment, and I suspect in many environments, cardiac CT techs are valued by hospital systems the same as a general CT tech. It seems to me that that's a problem that has to be solved in order for us to be able that differential has to be substantial. That's like, that's a little bit of a polemic, but I mean, the question is, to answer or do a counterpoint to that, or what do you say about that? Because it seems right now to be threatening my cardiac CT department, and I'm sure it's threatening others.
So when you have a CT tech and then crossing over into the cardiology space of it, there is a learning curve. But if you do have, so I'm going to answer this in kind of multiple stages here. If you have a CT tech that can be dedicated in the cardiovascular space, they're really going to become proficient in that one space. I will say Arineta has a very robust training program to be able to help with that hurdle. The other piece of it, if you're hiring for a CT tech within your office, when you are a technologist, being able to move into an office-based role is what you earn after you've worked at the hospital setting, because it's usually no nights, no weekends, no holidays. And so it becomes very attractive that you have a first shift position where you have patients that are usually walking into the table, not heavy lifting, but you're really focusing on one part, that cardiology part. Now, from a hospital perspective, yes, this becomes how do we manage being able to have those additional CT techs to be able to offer the hospital program in both the office space. But I do think that the office space may actually be at the advantage.
Well, that's an advantage, but I don't think it's sufficient advantage. You think it is
Well,
sufficient.
Go ahead.
If I can address that. So one of the hospitals that I read at, my home hospital at Paoli, there is a lot of disgruntlement amongst the CT techs for several reasons. One, we are capped at 3 cardiac CTs a day, just because we share that 256 dual source. It's a Force. It's a Drive. It's a Siemens Drive. It's a great scanner, but we share it with neurointerventional, stroke program, trauma surgery. So the CT techs and the nurses, frankly, are a little bit frustrated on a daily basis because they're doing a cardiac scan, they're beta blocking, they're gating and everything, and they have to take that patient off the table to do an acute trauma, a gunshot wound, a trauma, FAST scan, and so forth. Then the patient that patient leaves, then cardiac comes back on, then they have to take them back off for a stroke. So they're constantly flipping modalities. So there's a lot of disgruntlement and a lot of dissatisfaction just with the constant changes. We don't do cardiacs in the hospital after 3:30. But there are a ton of requests for late afternoon, early afternoon ER, CT, chest pain rule-outs. And so trying to fit them in, beta blocking, staffing. And so 80%, I would say, of our techs have looked for outpatient jobs because they are frustrated, they are tired of doing overnights. As a general tech, even the ones who are cardiac trained. So they're wanting to go to better work-life balances, and so that's something that the hospitals have to sort of figure out and how to manage those expectations. And I've had discussions with them, so we're trying to keep the cardiac techs during the day, but there are times where they're pulled in overnight due to shortages, and that affects the rest of the week, ripple effect.
Every area obviously is going to be different geographically. Our hospital, who I recruited my part-time technologist from, it was just bought by UCLA. Their pay went up, their pension's better. Hospitals get paid more money to do the same work that we get paid in the outpatient setting. To take a full-time technologist, from the get-go when I opened my place 3 months ago, I couldn't afford it. They make so much more money at the hospital. And then what happens when they have to go on vacation? They call out sick. They don't want to call. So I have 3 part-timers. And I'm not full-time yet. So our challenge is they're expensive. CT technologists are expensive, and
Yes.
especially if they're cardiac trained. I train them myself, and also with FSCCT, pay for them to go to attend the course virtually. And they're all gung-ho and they're all in, but they're expensive to get. In my area, at least in Los Angeles, because hospitals pay so much more money. And then you need more than one. You can't just have one. You need more than one. It's a challenge. I agree.
Yeah, I do agree that there needs to be an evaluation from a competitive pay part. There really is an advantage, though, of getting out of the hospital system. So as a technologist that worked in the hospital that went into the office space, it is a great work-life balance is a great way to state that. That really is a benefit to doing that. The other piece of it is you have a known schedule. So when you're working in the hospital, you're fitting in both inpatient, ER, everything's a stat. So how do you prioritize it to being able to come into the office space where you have patients that are scheduled and it's not this stacking of patients. So there are benefits other than the compensation. It's a great question. Okay.
I just want to make a note of that. Like we know that cardiac CT numbers are going up on a yearly basis. Since the changes of the CP code, we've seen that every year. Like we don't have a lot of cardiac CT equipment available. It's the same thing with CT technologists. Some of us started from the beginning of time, but now programs like this, like the SCCT, is giving us the opportunity for us to learn more. And I think as all of us members, that's what we need to advocate for. More education for new cardiac CT methods so we can attend. As a physician, you can also say, you know what, we want to send our techs out there so they can learn more. Now, on the physician's point of view, yes, there's not a lot of us doing cardiac CT, but we going through that transition to start training new techs. As you see, new equipment has become easier to manage now because they kind of automated. So it's making it easier now. The more exams that you perform, the better we are going to get. But for us technologists, we need the backing for the physicians and administrations for us to be able to come to places like this so we can learn, because we need to know how you guys see things in order for us to provide the quality images that you're looking for.
Okay.
Thank you, Dr. Warren. And I just want to let you all know that we will have a recording and speaker presentations on our website. We have a page called Webinars and Presentations. So if you go there sometime next week, we will have the video and presentations uploaded there if you would like to download it. And now I would like to introduce Doug Ryan, CEO of Arineta, who will conclude the session with final comments. Doug Ryan is a leader in diagnostic imaging, technology, and worldwide commercialization and business growth. In his different roles, he has developed and launched multiple generations of CT technology and has been a pioneer in some of the industry's most transformative breakthroughs over the last 30 years. Please join me in welcoming Doug.
Firstly, thank you all for coming this morning. The accent you hear is slightly blurted because I'm just recovering from bronchitis, but just to let you know, I've been working with cardiac CT since 1998 when we set up the Sydney Heart Centre many, many years ago. I'm extremely passionate about this industry. It's something that's very important to me. I've been aware of the Arineta technology now for a number of years. I truly think it's going to allow us to change the cardiac space. You've heard multiple times this morning about the wait times we're seeing in hospitals, and it's very real, and it's going to continue to grow. And so, we are really here to support you in trying to address access to that. We're very proud to have customers like Dr. Sheth, Dr. Cohen over here as well. Very, very pleased to have you all coming on board. We're extremely proud to be partnered with MedAxiom. I mean, one of the questions you're always going to have is, how do I do this? Buying the technology is one thing, implementing it, making it successful is another. And, we learn a lot from our existing customers, including many of the gentlemen in the room today, that this is a need that needs to be addressed, hence the reason we've partnered with MedAxiom. I know you all have sessions to go to this morning, so I'll keep this very brief, but again, thank you very much for coming here today. If you haven't come by our booth, please stop by. It's booth 306. We have an actual gantry on the floor that you can go and see the physical size of the system, and that's one of the core advantages of the fundamental design of this system is you can put it into a much smaller room than a conventional CT system. The question about technologists was very relevant, and there's a lot of onus on us as a manufacturer as well to make sure that our systems are very simple to use. And one of the things that we're constantly working on with every software revision is taking more and more feedback from our customers about how do we make this optimal to make sure that essentially you can take a technologist that is skilled and train them very quickly to be super skilled. And as Jamie hinted to, when you're doing a dedicated cardiovascular program, that learning curve is extremely steep and very quick. And so you can take a cardiologist and a technologist and come up with a very symbiotic program that works very efficiently in a short amount of time. So, but again, look, thank you for your questions this morning. It was wonderful to see you all here. And if you have any remaining questions, we'll be here if you want to come up and ask questions for a few minutes. But I know both Dr. Warren and Dr. Sheth have to get off to other sessions as well, so thank you.
Doug, one
Yeah.
thing that might help
Yeah,
is you get accredited, right? And
yeah,
emphasis on early accreditation would be helpful coming from the company. And say here, although IAC, for example, has all kinds of documents on the web that you can all have to be modified, some of them are old. It'd be really nice if you all could say, here you go, here's your documentation kit. Just go and upload all this stuff to the right spot on AAC, put your logo on it, and
yeah.
get it done the first week.
Yeah,
So.
absolutely, and we listened to everything you gave us as feedback, and that's one of the major reasons we've partnered with MedAxiom, is to exactly help you in that phase of introduction. So, yeah, no, good feedback. So, all right, team, listen, thank you for your time.